All right. First of all, have you guys kind of looked at the timeline for the next 10 days?
We have our adult health final on Tuesday at like 8, right? Or am I wrong about that?
We'll just kind of run through. Tomorrow is mental health ATI retake for some, right? Then some are taking the fundamentals retake on Friday. Some took it today. Saturday you have your mental health exam 6, which I'm gonna have a Kahoot that's coming out to help you study for that. Sunday the 4th is the day that your JERO exam opens up, but you have until Monday at midnight to complete that exam. Tuesday the 6th is your Adult 1 final at 8 a.m. according to the syllabus.
Tuesday, 8 a.m.?
At 8 a.m.
Okay.
Wednesday is a study day.
So Wednesday, are we going to study for mental health?
Yes.
Okay.
We will have our regular 1 to 3 study meet. And then Thursday will be your mental health final at 9 a.m. Okay?
Hey, Gabe is giving us an extra hour of sleep.
That's just kind of how the final exam.
No, it's nice.
Bell.
It's cold outside.
Okay. Alright, just a second to get logged in on here. We'll get going on the adult final study. Okay, so post-op care. When we are doing our assessments post-operatively. What are we looking for?
Vital sign changes.
Vital sign changes, yes.
ABC.
Yep.
Who said that? That was loud.
And the first indication that there is something going wrong, what do we need to do?
Assess the airway.
Yes. Right, so we've assessed our patient and we are concerned that there is a problem. What are we going to do?
Call the doctor.
Right? Call the doctor if it's something that can wait. What do we do if it's a drastic change?
Rapid response team.
Yes, call the rapid response team. Okay, what's the most important thing that we assess for preoperatively as a nurse?
Consent forms.
Well, we have to make sure that consent signs.
Allergic? Allergies? No.
Well, kind of goes with it, Ellen. Reactions, but why might a patient have a reaction other than allergies?
Are you talking about
Like this type of social assessment, like do you have a support system and are you comfortable and stuff like that?
the patient could have an infection, even though it could be the best doctor.
No, not.
Yeah.
That's important pieces, but there's something that I'm looking for that we have to double check preoperatively to prevent reactions
Allergies,
during surgery.
blood type.
Anesthesia.
It all plays a part with that.
Ethnicity, if they're like,
The physical condition.
if they can, if they have, if they're taking like a medication.
There you go, Ellen. What medications are they taking? Important part, probably one of the most important parts, is their medication list. Because if we give them something during surgery, or they have a sentinel event during surgery, and we don't know what medications they're taking, we could cause a more adverse event if it counteracts with something that they're taking, right? Okay, whenever we're talking about patient-centered care, what do we need to keep in mind?
Or hygiene.
Safety.
Culture sensitivity.
Culture is one of those. But cultures kind of fit into this.
Religion considerations.
It goes with it too. Are we going to talk to a patient that, say I'm a patient? Are you going to talk to me the same way that you would talk to a farmer that comes in as a patient?
No.
No.
So what's the difference?
You still
You
go
just,
to the
oh, sorry.
What's the difference?
terminology. Use the vocabulary, the language that they understand.
Their competency, right?
Yeah.
So we need to understand their level of competency and their also any beliefs or faiths that they have, right? So we need to keep all of that in mind and individualize the care, correct? We want to feel like the patient, or we want to make the patient feel like they are in control of their care. What's the best way to assess pain?
Self-report.
Self-report.
Yes. Pain is what the patient says it is. Okay. Explain to me about older patients and assessing them for pain.
They might not always feel as much pain as they're supposed to. Like, they kind of have less of a, or I guess more of a pain tolerance, just because they have like more numbness and stuff.
Right? They might, because they might have some neuropathy, right? But they may have the pain, right? And they may just think that it's normal and they shouldn't complain about it because they don't want to be a bother. And they don't want to get addicted to that medicine, so they don't want to take it. Because they've heard all kinds of bad stuff about it. So as a nurse, what is the best things that we can do to get the best accurate prediction of their true pain?
Their faces, maybe?
What'd you say, Ellen?
Their facial expressions.
Their facial expressions. Yeah, we could use the FLAC scale instead of a verbal scale, right? But the best,
Faces.
the what?
Faces, pain scale.
Or the faces pain scale. But what's the best indication of pain?
Oh, 1 to 10. It's scale.
A verbalization of pain, right? So if they think that it's normal and they don't want to be a bother, how can we as nurses get them to give us a more accurate indication of their pain?
Have them describe what they're feeling.
Yeah, we could have them describe it. And as you're having them describe it, what do we need to do?
I would be thinking like tell them what the pain scale, like say 0 is no pain and 10 is like getting hit by a bus, something like that.
Right, which I don't doubt that they don't understand what 0 to 10 means, right? They know what it means. But they're like, it's okay, you know, it's normal to hurt. I'll be okay. I can deal with it. I don't want to bother anybody. You're busy. You're running around. I can see that you're way busy and I don't want to bother you. And it's surely not that bad. How are you going to deal with that? Especially when they're not properly doing their ADLs and you can tell that they're in pain. As I just had grandma that had a knee replacement and she needs to do her therapy, but she's not bending her knee like she should be because she's hurting. But she's not telling anybody because nursing is shorthanded and she sees you poor little things running around nonstop. And she's just worried about you. She's not worried about herself because she can just sit there and she'll be fine. What do you need to do to get her to give you an accurate indication of her pain?
The numerical one? I mean, no, it's still verbal.
What?
The numerical scale? Or is it still verbal?
She's verbal. Yeah, she's completely alert and oriented.
Oh no, I'm saying like the numerical scale.
Right. Yes, we want her to use the numeric scale. But if you're running around, is she going to give you an accurate number?
Spend more time with her.
There you go, Marina. You're going to have to slow down, maybe even sit down with her, Show her that she's not a bother to you. And allow her to tell you truly what's hurting her and what's going on. Because little grandma, she's just worried about you. She's not worried about herself. She sees you running around the unit and she's worried about you. She's just fine sitting in that chair. I'm not moving my knee, so I'm fine, honey. But is it fine for them to sit there and not move their knee after a knee replacement?
No.
No, it's not. We need them to do that therapy because otherwise they're not going to heal properly. And we need to make sure that they understand that they're not a bother, and we need them to take that pain medicine. They're not going to get hooked on it just taking it long enough to be able to do their therapy. Because that's another thing that they get in their mind, is that if I take those pain pills, I'm going to get hooked on it and somebody might accuse me of doing drugs. Because that's the generational thing. The baby boomers. They saw opioids as nothing but a negative thing. Okay, so talking about Jero a little bit more in adult here. Who's at greatest risk for dehydration? Older adults, but more than just older adults. What other factors?
Hospitalized, bedbound. They live alone.
Dementia patient.
The what?
Dementia.
Dementia, yeah, the cognitive impairment. That's a big part of it. Because they're not going to get fluids independently, right? I mean, any comorbidities and over the age of 65, they're at a higher risk. But if you add cognitive impairment on top of that, are they even going to realize that they haven't been drinking fluids? Guys, if we ever suspect a complication with an IV infusion, what do we do?
Stop the infusion immediately.
Yes.
And DC the catheter.
Not always.
If there's an infection? Or if we suspect one?
We don't always immediately DC the catheter, but we are going to stop the infusion. Okay. We're talking about metabolic alkalosis. What causes metabolic alkalosis?
Diarrhea, right? Or is it vomiting? It's one or the other.
What is metabolic alkalosis?
High pH, low bicarb levels.
Do you have a lot of acid or a lot of base?
Out of base.
A lot of base.
A lot of base.
So vomiting.
Yes.
Julie, I'm so sorry. Can you repeat what you just said?
With metabolic alkalosis, I said, do you have a lot of acid or a lot of base in the body?
A lot of base.
And it's a lot of base with alkalosis. So if you have metabolic alkalosis, more than likely you are either vomiting excessively, or what's another reason that we could have metabolic alkalosis?
Muscle
Taking
weakness.
too many, like,
It involves muscle weakness, taking something.
I was thinking,
Yes.
like, yeah, like taking the gastric acid, like antacids. If you take too many antacids, it's gonna make you basic, isn't it? Or like pantoprazole. It's like the acid reducers. That's what I was thinking. That's probably wrong.
It would take quite a bit. I mean, it's possible, but it would take quite a bit. I'm thinking of a medication.
Melanosid loop diuretics.
She is absolutely correct. Diuretics. Especially loop and thiazide diuretics. Lead to metabolic alkalosis. So that's just two of the major causes. There is more, but that's two of the major. Okay. What's patient teaching post-op of an abdominal surgery?
Teaching post-op or abdominal surgery?
Teach bracing when coughing and stuff like that, using the incentive spirometer to avoid respiratory issues and breathing sutures.
Right, yes, that's a very important piece. We want to make sure that they are deep breathing and coughing, but we also need them to be taught how to splint their incision so that they don't bust anything open while they're doing it, right? Because shallow breathing is going to lead to what?
Collapsed lung.
Collapsed lung or what? If they're not breathing good, like they're not taking good deep breaths, what's going to happen in the lungs?
Respiratory alkalosis.
Yes. But I'm looking for what type of respiratory problem. It kind
Pneumonia.
Yes, there you go, Lana. It's pneumonia. That's what we are always trying to prevent post-op. Because anesthesia does not do us any favors on our deep breathing, right? So we need to make sure and coach our patients to take good deep breaths and do our cough and deep breathing techniques along with our incentive spirometer. Okay, so if we're dealing with a COPD patient, let's say, that has shortness of breath all the time, and we are trying to get them ready to be able to discharge home. What are major things that we have to plan for?
They understand how to use their medications, their respiratory medications.
Yes. What else?
Oxygen therapy at home.
Yes. What else?
Take frequent breaks when they're ambulating.
Yeah.
Yeah.
Like when they're doing with meals and activities to take frequent breaks, like Eli said.
And small meals with that too.
High calorie, high protein diet.
Yeah. How about safety?
Oxygen, don't put it near flames.
If the patient has constant oxygen, they should be taught to constantly understand like the risks that come with oxygen usage in their home.
Right, so we need to make sure they know all about oxygen and the safety with that. But what about safety of the patient? How do we know if the patient is safe to go home?
If their oxygen sat is steady, I'd say within 89 to 93.
Mm-hmm. Okay. If their oxygen stats stay up, during what?
Walking or standing.
What else do they have to do to be able to go home? They have to do more than just walk and stand. What do they have to do?
Feed themselves? Yeah.
ADLs? Sorry, I don't know for that.
Yeah, they're ADLs. So we have to figure out if they need assistance with their ADLs or not, right?
Is that all for COPD?
Well, for that one, but whenever we're talking, this one's talking about oxygen therapy. What can we delegate out about oxygen therapy?
Not a lot.
You're right, not a lot.
Help feed?
Oxygen therapy?
No, not oxygen
We're
therapy.
focused on oxygen therapy. What can we delegate out about oxygen therapy?
Make sure he's good, please.
Make sure what?
Like it's in a good spot.
In place? Yeah. We can make sure it's intact and at the right leader. Yes, we can have them check the nasal cannula.
Can they put petroleum on their nostrils so their skin doesn't dry out?
Do we use petroleum?
No.
No.
Like, use
Use
water
water-based.
salt.
Water-based one.
Water soluble ointment. Yes, they can put water soluble ointment on the nares and lips. Yes,
That's all we can do.
that's not all they can do. They can check the nasal cannula. Can they apply a nasal cannula to a patient that already has established oxygen?
Yes.
Yes. They cannot initiate oxygen therapy
Or titrate it, or
or adjust it in any way. They cannot replace tubing with a different type of tubing, but they can replace the tubing with the same thing. Right, so if the nasal cannula is damaged, they can go get another one and put a fresh one on them as long as it's the exact same thing at the exact same liter flow as the patient had on to begin with. They can make no adjustments whatsoever. But they can apply a new nasal cannula.
How many questions are in this test? 50 or 75?
I want to know that too.
Hold on.
I don't know, I just out curious right
50.
now. Okay, thank you.
There's a total of 50 questions.
Do you know if any of them are like self-qualified or anything?
Don't know yet. Okay. How do we assess nasal drainage to see if there's any cerebral spinal fluid?
You put it on a piece of filter paper, and if it dries with like the halo, then it's
Right. We use the filter paper, and if it dries with a halo, we know that there's cerebral spinal fluid. When is the most likely chance that there's going to be cerebral spinal fluid?
head trauma.
Head trauma. Yes. Fractures is the most likely time that we're going to assess for that. Can it happen other times?
Yeah.
Yes, it can, but it's not as likely. Okay. So if you have a COPD patient come in that's been diagnosed for some time, but they come in and they look thinner than normal. And just not right from the last time you saw them. What type of questions are you going to ask?
I'd ask about their diet,
Yeah, they might ask about their diet.
their management of their COPD.
How are we going to find out about their management of their COPD, though?
If they've been short of breath lately, what's their activity level been? What was their last like O2 sat or the past over month or something like that?
Right, so we need to get a baseline of their activity level, right? Because if they say, oh, I've just barely been moving around the house and I just can't hardly even breathe to get up and make a sandwich and sit back down. And then I can't even eat half my sandwich without being out of breath. Is that a problem?
Yeah, because their disease isn't managed well.
Right. They're in an exasperated state, right? But if they say, oh, I've been so busy chasing around, going to all my grandkids' ball games, and I just have been too busy to eat,
Then you'll be like, oh, okay.
that's a big difference, right?
That the volleyball team won.
Oh, they won?
Yeah, they're
They
good.
were losing.
They're
First
losing
time
in the
losing to Sri Lanka.
Okay,
And then
so-
they won
1-3-2.
3-2.
when patients come in with COPD exasperation, what is a normal fluid and electrolyte imbalance that we see?
one of the respiratories.
It's actually, well, it is respiratory related, but you don't always relate it to respiratory. Let me put it that way.
Can you repeat the question?
I said, when you have patients that come in with COPD exasperation, what's a fluid and electrolyte imbalance that we see a lot of the time?
Low salt, low potassium.
Yes? Can you tell me why?
Water retention due to heart or renal failure for hyponatremia. And low potassium can occur due to medication like beta agonists and diuretics and can worsen respiratory muscle function, according to Dr. Google.
Dr. Google is not always right. You are right on the imbalances, right? We can have potassium and sodium and sometimes calcium off, and even magnesium on occasion. think about it, guys. We have COPD patients that have been short of breath. What type of breathing are they doing?
Shallow.
Shallow what?
Shallow breathing.
Shallow quick.
Shallow quick. What other kind of breathing do we see? What do we call that? What do they look like? They sit up, tripod breathing. Or they're, I always say this funny, I'm terrible with pronouncing that word. It's horrible. Uh-huh. So, can that cause dehydration?
Yes.
Yes, it can. Does that cause a big shift in your fluid and electrolytes? Yes. Yeah. A lot of the time, COPD patients that come in exasperation are also dehydrated. They come in two ways. They're either fluid overload or dehydrated.
So the dehydration comes from how they are breathing.
Because of the way they're breathing, yes. It's the rapid breathing and the continuous expiration. Okay, what diagnostic tests do we use for respiratory problems? ABGs. What else?
PFTs.
PFTs. What else?
Chest X-ray.
X-rays? Yes. Now what's the more invasive thing?
Respiration count.
That's not more invasive, but yes, we count respirations. So if we've done an X-ray, they've done PFTs, they've done the ABGs, what might be a invasive procedure they do for like a COPD or a pneumonia patient? Especially if they have like
Fluid?
a mucus plug.
Oh.
Sputum culture. No. Okay.
Invasive. Think invasive.
They.
Bronchoscopy.
There you go, Rachel. A bronchoscopy. They're going to go down in there and they're going to wash everything out. Or they may go down and do a biopsy if something was seen on an X-ray. Okay. So we're doing an assessment on a patient. What might be an indication to us that the patient is having some peripheral edema?
Heart failure?
Yeah, right side.
You're doing an assessment. You're asking questions.
Or daily weight. They feel an eye, they cannot tie, or the sock, I don't know, it's too tight.
What is it? What? What'd you say?
Daily weight or an eye as the patient if their feet get too tight in their socks or shoes.
Yeah. So daily weight is the best way to track fluid balance with congestive heart failure patients, right? But if we're just doing an assessment on edema, Ellen, you're exactly right. We might just ask them, how do your shoes fit at the end of the day? Are they really tight compared to when you first put them on? So, which type of heart failure?
Right side.
Yes, right-sided heart failure is the type of heart failure that we have to worry about peripheral edema. And weighing the patient is always going to be the best assessment for fluid fluctuation.
What? For fluid what?
Shifts in fluid. I said fluid fluctuation. So if we are, especially if we're diuresing patients and we want them to have a decrease in fluid, we're going to see that there was significant drop in fluid by a loss of weight.
Okay.
Okay, what is the big risk with artificial valve replacement?
Clog.
AFib?
Clog. You clog.
Clots.
Clots.
Yes,
Yeah.
blood clots. That's exactly right.
So they need to take warfarin for the rest of their lives.
Yes,
Or blood thinner for the rest of their
right.
lives.
And more than likely they will be on warfarin for the rest of their life, because the prosthetic valves are more prone to blood clots. Okay, with bone marrow biopsies, what is our major concern? Post-procedure.
Infection and bleeding.
Yes, infection and bleeding. But what comes first?
Airway.
Infection.
Not infection.
I think it's bleeding.
It's bleeding. ABCs, always. What does a lymphoma look like?
Like a ball, etc. I don't know.
It can be like a lump under the skin, right?
Oye, me pisan.
Are they painful?
No.
No. What do the lymphoma involve? What?
The lymph node.
Yes, the lymph nodes.
Lymph nodes. They're, I don't know. They're kind of like,
Yeah, it's the lymph nodes.
yeah.
So it's just an enlarged,
Lymph.
painless lymph node. Okay. If we are dealing with a patient that has had a knee replacement, do we automatically freak out if the patient has cool skin and just a 1+ pedal pulse?
Compared to baseline.
How do we compare it to baseline if they're post-op?
from your pre-op assessment.
What if the nurse
Use the leg as a comparison.
do what?
Use the other leg as a comparison.
Yeah, we can use the other leg as a comparison. Ideally, we've been the same nurse. We had them pre-op and post-op. Does that always happen? No, it doesn't. Does the nurse before always do the best documentation? No. So if that happens, you can compare it to the opposite leg. And if the opposite leg is the same way, do we need to be concerned? No, we do not. All right, tell me some patient teaching about osteoporosis.
Carbonated drinks, females, postmenopause.
Okay. What are some risks associated with osteoporosis?
Falls.
What's the concern?
Fractures.
Yeah, it's fractures
Okay.
associated with falls, right? We're worried about that they're at higher risk of fractures if they fall because of what is osteoporosis doing to our bones?
The density go lower.
Right, they're making them more fragile, right? Makes them more fragile. Okay. Should patients with osteoporosis just stay in bed?
Oh,
No, they shouldn't, right? They should be encouraged to do what type of exercise?
weight bearing.
Weight bearing. Things like walking. Is teaching the patient to eat a high calcium diet gonna fix the problem?
No.
No. Why is that?
Because it's hormones too, as well.
Right? It's hormonal too, but if you're already diagnosed with osteoporosis, the bone loss is already severe, right? Increasing your calcium in your diet is not going to make a difference at that point. Okay, what's post-op teaching from total hip arthroplasty?
Patient needs to get up and walk around. so that the muscles don't atrophy and the surgery doesn't project.
Mm-hmm.
Avoid hip flexion beyond 90 degrees.
Right?
Avoiding cross your legs. Right? Crossing their legs.
Oh, yes. We don't want them to cross their legs. That's right.
Aren't they also supposed to have like a pillow in between their legs because it's the adduction that'll like dislocate their hip?
Yes, sometimes they use a wedge pillow, they call it. Okay, how about immediately pre-op or during surgery? What's some things that they do for hip arthroplasty? What do they do to help reduce blood loss?
No, no question like that.
Avoid smoking.
There's a medication that they give to help reduce blood loss during surgery.
Do they give them vitamin K?
No.
NSAIDs.
Would NSAIDs promote blood loss or increase blood loss? Increase blood loss, yes. It's anybody else want to guess?
Blood thinners. That's my last guess.
Nope.
What was the question again? Sorry.
What do they give during surgery to reduce blood loss?
Clotting factors?
I remember. There's the medication. Wait. Tranexamide acid. No?
Yes. You said it better than I did. I can't talk today, guys. Tranexamic acid.
TXA. Oh.
TRANEXAMIC. Tranexamic acid. There we go. Now, what is something else? This kind of involves anesthesia. What's something they do immediately before they operate that helps with pain management?
A sedative.
Does it have to do with asking like what their baseline level of pain they're willing to deal with is so that they know post-operatively what or when they should administer pain medications?
No. Why can we not get hip replacements up normally for the first 12 to 24 hours?
Because they have the nerve block.
There you go. Because they typically get a regional nerve block also, along with general anesthesia. What else do we do? What are they at huge risk for?
Aspiration.
Aspiration and
I mean, they could move, so bleeding. No.
I mean,
They're not feeling
bleeding is a possibility.
infection.
Infection. There's a big chance of infection with hip arthroplasty. So what are we going to give them preventively beforehand?
Prophylactic antibiotic.
There you go. Prophylactic antibiotics. Now, post-op wise, we're going to start them on blood thinners, right? Because you're at high risk of getting a blood clot post hip arthroplasty. But how do we administer that blood thinner?
IV.
Sub-Q in the belly.
Yes, Rachel, it's sub-Q. Do we ever administer IV heparin before or after a surgery? Absolutely not. Okay, why do we use skeletal traction?
For proper alignment.
To reduce fracture.
Yeah, proper alignment, reduce the fracture, keep it in place so that what?
So the bone realign. No.
Yeah, so that everything heals correctly, right?
Mm-hmm.
So it's going to realign the fractured bones and hold everything in place so that it properly heals. Okay, so if we have a patient that has been on several antibiotics post-operatively, what could happen to that patient? I mean, it doesn't even have to be post-operatively. We just have a patient in the hospital that's been on several antibiotics. What can happen to them? Diarrhea. Why are they getting diarrhea?
C. diff.
C. diff. Why do patients that are on multiple antibiotics get C. diff?
Because it kills the good bacteria too.
Right, yes, it kills the normal flora in the intestine along with the bad stuff, right? So, what do we have to do if a patient starts to have frequent diarrhea and we know that they've been on antibiotics?
Stool sample.
Yes. We need to call the provider and get an order for a stool sample. Run a stool culture. All right, what are some of our musculoskeletal diagnostic procedures?
DEXA scan.
Okay. What else?
MRI.
Okay. What else?
A CT scan. CAT scan.
Yes. Anything else you can think of?
X-rays.
Yes. What about some more invasive things?
Bone marrow biopsies.
Yes. We also have arthroscopy
Oh, that's right.
and nerve conduction studies. All right, if we have a patient that has leukocytosis, what does that mean?
Increase white blood cell.
Mm-hmm. Over what then? What number?
For 11,000? 11?
Yeah.
Yes. At least. It's going to be at least 11,000. Most of the time it will be over 12,000. How do we diagnose gout?
The uric acid test. I don't know what it's called.
Uric acid Just the uric acid level. But what is that? What is gout?
When you have too much uric acid in the blood.
Stomach.
Inflammation of the joints.
Right, you have uric acid crystals in the joints. So, acute osteomyelitis. Tell me what that is.
Soft tissue.
Infection in the bone.
Alright.
Yes, infection in the bone. Okay, if we're assessing an abdomen and a patient has a point of tenderness, how are we going to assess that abdomen?
Let the point last while you're gonna palpate, and palpate like softly.
You're going to do the point of tenderness
Like the last.
last. Yes, exactly right.
Yeah.
We don't want to even touch the tender spot until we've checked everything else. And do we ever want to palpate a tender spot aggressively? No, we do not. Okay, so if we're dealing with oral cancer, think safety. What is our major problem, concern?
Their airway.
ABC, yeah.
Their airway. Is it easy for patients with oral cancer to swallow?
No.
No, it is not. Okay. If we have a patient that has a peptic ulcer, what's our major concern?
Bloody diarrhea. And bloody stool.
Bloody. So what's our concern? Bleeding. GI bleed. actually had a GI bleed this weekend, guys. So I can tell you a case study here. So, Sunday morning, 7 a.m. I love when I get these things first thing in the morning, right? It's so great. Get your day going great. First patient I went to assess the day. I went in the room, and this patient was a little lethargic to begin with. Like, she was not, she had some other things going on. But I went in to assess her, and I noticed that there was some brown, dried on stuff at the corner of her mouth. And I'm like, that cannot be good, right? So me, the nurse I am, the first thing I do is go grab some wipes, because I'm like, oh my goodness, I have to clean her face. I can't stand her to have dried brown stuff on her face. So I go get a wipe, and as I'm cleaning her face, well, then she proceeds to vomit again. And it was dark brown, almost looked like coffee that she was vomiting.
Oh, it was a latte then.
Yeah.
Yes.
So, tell me what she had.
Ulcer?
An upper GI bleed. Obviously, she did not stay at Fitzgibbon because we do not have a GI specialist. I got her shipped to Columbia as soon as I could because she continued to vomit blood.
Oh.
And it was, it was dark blood, so we knew it was coming from somewhere deeper, right? So it was stomach or a little lower, right? Because if it wasn't, it would have been bright red, right? So I finally got a call from, she ended up going to Boone Hospital in Columbia. And I got the phone call that I didn't want to get, that she had passed away.
Oh.
Because she had a full perforation. And not only did she have a perforation, she also had several tumors in her intestine. So, they think that the tumors had caused the perforation. But the only good thing is her quality of life was not ideal. And she was in her 80s to begin with. But it's still not the phone call that you want to get, right? Thankfully, I felt like I had done everything I possibly could because I found the situation, I acted on it fast, I got her to a tertiary facility where she could be taken care of as soon as possible. Still not the outcome, but unfortunately, that's not the first time, nor will that be the last time that happens to me, right? So, the way we learn to deal with that is, like I said, I know that I did everything in my power to act as quick and efficiently as possible. So, kind of goes with the next one. If we have a patient that is diagnosed with colon cancer and it gets removed and they have a new colostomy, how do we help them deal with that?
Emotional support.
Emotional support.
So a group, assisting group.
Right. We're going to refer them to a support group. Oh, Ellen, we talked about this. What sound do you hear with Crohn's disease?
Oh, like kind of like crackles. I don't remember.
You don't remember? So what happens with Crohn's disease? Anybody help her out?
So the left side, lower left.
Lower right.
Okay. Oh, okay. Like it's gonna build up like kind of stones, and then you're gonna be malnourished.
You will be a little malnourished, but Crohn's disease,
I mix it up.
yeah. What is that? Anybody want to help her? What's the bowel sound that we hear in the right lower quadrant with Crohn's disease?
I don't know.
So you have that narrowing of the bowel,
Oh yeah.
right?
High pitch.
Yes. High pitched. It's a high pitched rushing bowel sound in the right lower quadrant with Crohn's disease. Okay, what is a potential complication of TPN?
Aspiration. Oh no, it's
Aspiration is a risk.
Oh yeah.
How do we prevent that risk?
Sitting, flowers position. Sitting position.
It doesn't have to be high fellers. They just have to have the head of the bed.
Oh, the better. 45.
Hyperglycemia can be a complication of TPN, correct?
Right, it's hyperglycemia. And aspiration is a risk factor of an NG tube, not TPN. Let's get that right? So if they're having feedings being into the stomach, we have to be careful of aspiration. But TPN goes into the vein.
Yeah.
But yes, hyperglycemia. Why is it hyperglycemia?
Because of the high.
Because they go from potentially being malnourished to being loaded up with nutrients and stuff that's in the TPN and just cause them to go to hypoglycemic, not necessarily hyperglycemic shock, but it shoots their levels up.
What is that syndrome?
Refeeding syndrome.
There you go. Refeeding syndrome. We have to watch for that. Okay. High Fowler's position. We were talking about that, right?
Mhm.
What procedure do we put them in High Fowler's for that goes along with all this GI stuff that we've been doing?
NG too.
Could be an NG tube, but it's a little more invasive than that.
Paracentesis.
There you go. Paracentesis. So why do they need to be in High Fowler's for a paracentesis?
For the risk of aspiration. No.
No, not risk of aspiration. Why do we want them
Infection.
to be sitting up whenever they're aspirating fluid out of the peritoneal cavity?
Because of infection.
No, not because of infection.
Shift the fluid forward.
Right. If they're laying back flat, are you going to be able to get all that fluid out of the abdomen? So we want them sitting up and almost leaning a little forward, right? To promote all of the drainage that we can.
Elijah, next time we need to say aloha.
So,
Isn't it your friend? Say
I don't know
aloha. Aloha to them.
I can give them a luau after, right?
Okay, so when we're talking about liver problems, cirrhosis can be a cause of liver cancer. But what's one of the leading causes of cirrhosis?
Hepatitis C.
There you go. Hepatitis C. It's like a chain reaction. You get hepatitis C, it can lead to cirrhosis, that can lead to liver cancer. Who other than alcoholics are at high risk?
African Americans.
Yes, that's one, but I'm thinking of a certain syndrome.
Oh, it's the NAFLD, the non-alcoholic. No. Oh, this one's for hepatitis B and D. So it's the non-alcoholic fatty liver disease. Right.
Right.
That's what I meant.
Metabolic syndrome, right? Your apple people,
Yeah. Oh, okay.
the big abdomens. Your diabetics, fatty livers, high cholesterol. Probably have bad kidneys too. All right, tell me about lactulose. The medication.
It can help with ammonia buildup in the body.
Ammonia buildup. And what else do we use lactulose for? Constipation, right. So cirrhosis patients might have lactulose prescribed to them to lower ammonia levels in their body. But in general, lactulose might be prescribed just to relieve constipation. Okay, if you have a patient that's admitted with severe boring abdominal pain, what are you highly suspicious of their diagnosis?
Pancreatitis.
Yes, Rachel, pancreatitis. They're going to be the ones that are buckled over in pain. They're going to have that 10 plus. What else are they potentially going to have?
Nausea, vomiting, jaundice.
Mm-hmm.
Maybe less upper quadrant pain. Sorry to cut you off, Rachel.
It's going to be more than likely all the way across the upper abdomen. But they could also have nausea, vomiting, fever, jaundice, but those may or may not be. The priority problem that they always come in with is going to be that severe abdominal pain. Okay, following a EGD procedure.
Gag reflex.
You already knew. What is top priority with a EGD, with a bronchoscopy, everything? What's top priority?
Airway.
Airway. You cannot put anything in that patient's mouth until you make sure that they have a gag reflex. Okay, if we're going to be diagnosed type 2 diabetic,
Wake up. Eat better than that.
well, what's my A1C going to be if I'm positive for type 2 diabetes?
Over 120.
Our A1C.
Oh, okay.
6.5.
It's over, yeah,
Yes,
6.5.
6.5 or greater. Okay, if you are assessing a patient that is diabetic and you notice they have some scar tissue in one spot on their body, what are you suspicious that they're doing?
They're not changing the size.
There you go, Marina. They're probably not changing their injection site, right, for their insulin. What is that going to cause?
The tissues won't absorb the insulin, so.
Right. It might not absorb the insulin correctly, and it could potentially cause some cellulitis. So we want them to use the same
Right.
general region, but we want them to rotate their sites. When I have a patient come into the hospital and I know they use insulin at home, if I'm going to give them their insulin shot, I ask them, hey, where do you normally give yourself your shot? In the arm or the leg or the stomach? Because I'm going to continue and give them their insulin in the region that they normally do, right? And sometimes my patients prefer to continue giving them their insulin, and that's fine. I usually will just dial it up for them and let them give it to themselves, especially if they are have been diabetic for many years. Sometimes they prefer to do it themselves. So if you have a post-menopausal woman and you find that her uterus has increased in size.
Cancer. Ovarian cancer.
It is a sign of concern, right? It could be an indication of cancer. Definitely needs further looking into. Where's the most common site that we find breast cancer?
Right, upper quadrant, next to the axilla.
Right.
Oh, yeah, depends. Yeah, it's more next to the
Outer,
quadrant.
upper outer quadrant, right? And if it is potentially malignant, what is the characteristics of the mass?
Unmoved. Painless.
Yes, it's fixed
Fixed.
and
Tender.
non-tender.
Not tender, yes.
Yes. Okay, guys, it is 3 o'clock. We got through all of them except for the last 5, and they are all 5 questions that you saw on exam 7. So I honestly think that you are going to be okay. Okay?
Bye, Julie. Thank you.
Yay.
Thank you so much, Julie.
You're
Thank
welcome.
you.